It's a great pleasure for me to present Professor Pierre Gamarenko with the lecture
from Morocco.
with the lecture Reduce Stroke Risk in Type 2 Diabetes. Can we learn from the trials?
Yeah, thank you for introduction, and thank you again, Jean-Charles and Jamila, for the invitation to this meeting, which is very interesting for me as a stroke neurologist. You know that after 3 decades of clinical trials, they have been funded by the industry, pharmaceutical industry. There have been hundreds of clinical trials done in acute coronary syndrome and prevention of cardiac disease. There have been only 3 trials funded by the industry. One dedicated to stroke. One was the Sparkle trial in prevention, atorvastatin versus placebo by Pfizer, and 2 by AstraZeneca with ticagrelor, and each time at the end of the development of these drugs. So it's a shame for the pharmaceutical industry, because as you know, there are more stroke in Asia, for example, and it's more prevalent than myocardial infarction. It's a second case of death, the first cause of disability. This is my disclosures. And according to the Global Burden of Disease in 2016, according to the Global Burden of Disease, there's no light. Okay. 1 human in 4 will have a stroke in his lifetime. 1 in 4. We are 40 in the room, 10. So, and this starts at the age of 25. And it is true at every decade of age. So everybody is concerned by this burden of disease. So I think that for the future, stroke should be considered very early in the development of drugs, with dedicated trial, not only stroke among other disease. And also, we should consider brain health, that is vascular cognitive impairment, for example. This is one of the major outcomes for the pharmaceutical industry to consider in the future years. So, what are the risk factors of stroke? Of course, as you know, hypertension. Can I have a pointer? This one? Okay, sorry. Hypertension is, of course, in the interstroke study, the most important risk factors, with a population attributable risk almost 48%. Second is physical activity. And the third is a ratio of ApoB on ApoA1. Lipids are definitely a risk factor for stroke, and the population attributable risk is almost 27%. Diabetes has a low population attributable risk, but this is due to the prevalence of the disease in the population. Altogether, this factor accounted for 91% of this risk, of the population attributable risk in this study. So, coming to lipids, the Sparkle trial, the only trial dedicated to stroke, was out in 26 and found a significant effect of atorvastatin 80 milligram versus placebo in reducing stroke. Reducing major coronary event in this patient with a stroke at baseline. And in patient with carotid stenosis, a subgroup of Sparkle, there was a 33% relative risk reduction with a very early divergence of the curve. And in this population, again, there was a 42% relative risk reduction of all major cardiovascular events. So in Sparkle, patient randomized with type 2 diabetes had the highest risk of recurrence, 18% at 5 years, 80% of stroke, and they also had a very strong 30% relative risk reduction of stroke. As usual with diabetes and statin, we know that stroke is very responsive. In Jupiter, it was 50%, for example. In Sparkle, any coronary heart disease endpoint were reduced by 51%, revascularization procedure by 64% in diabetic patients. So these patients are really responsive to atorvastatin 80 milligram. And a very interesting observation in Sparkle was about renal function, particularly in diabetic patients. In diabetic patients in the placebo group, as expected, we had a degradation of the renal function. But this degradation was not observed on atorvastatin 80 milligram, suggesting that atorvastatin 80 milligram was nephroprotective. In Sparkle, we gave 80 milligram atorvastatin, so we expected to have at least 55% reduction in LDL cholesterol from baseline. So we looked at the group with more than 50% reduction in LDL cholesterol from baseline as compared to the group with no reduction or an increase, and you see that there was a 31% relative risk reduction. It was true also for ischemic stroke. And in hemorrhagic stroke in this group, there was no increase in hemorrhagic stroke. We also looked at patients who could achieve less than 70 milligram LDL cholesterol during the trial. I remind you that on average at baseline they had 133 milligram LDL cholesterol. So those achieving less than 70 milligram LDL cholesterol had a 28% relative risk reduction. And this is what we wanted to confirm, because it was a post-hoc analysis. We wanted to confirm in the Treat Stroke to Target trial. And in the Treat Stroke to Target trial, we selected patients with atherosclerotic stenosis, stroke and a TIA, and we randomized them to either a target LDL cholesterol less than 70 milligram or a target LDL 100 plus minus 10 milligram per deciliter. And we followed the patient. So we could use a statin, ezetimibe, or whatever, to, and titration of the drugs to reach the target assigned by randomization. So before the result, we saw that during the trial, the blood pressure was well controlled in both groups according to guidelines. Patients who were active smokers at baseline stopped smoking in 75% of cases, which was good. And also we had a fairly good control of hemoglobin A1c for patients randomized with diabetes, 23% of the sample. In the higher target group, they started with an LDL cholesterol of 136, and they went down to 96 milligram per deciliter. but still 17% of the patients were above the target, and 48% of the patients were below the target. In the and for this we use statin only in 94% of cases. And in the lower target group, they had a similar LDL cholesterol at baseline, and they went down to 65 milligram per deciliter. So we really had the contrast we wanted to have by a trial hypothesis. And 47% of the patients were above the target. 45% had an LDL 50 to 70 milligram per deciliter, and 8% less than 50 milligram per deciliter. Overall, the time in therapeutic range, that is the time spent below 70 milligram per deciliter during the trial in the lower target group, was 53%, only 53%. And to achieve this, 2/3 of the patients were on intense or moderate statin therapy, and 1/3 on statin plus ezetimibe. So the primary endpoint, which was a composite major cardiovascular event, the median follow-up was 3.5 years, and we had 11% in the higher target group and 8.5% in the lower target group, yielding a 22% relative risk reduction and NT42. And the adjusted and non-adjusted odds ratio was similar and significant. The group, which was the largest, who had a median follow-up of 5 years, had a 13% risk in the higher target group, 10% risk in the lower target group, and 26% relative risk reduction, and significant. So, as I said, the patients in the lower target group spent 1/3 of their time in dual therapy with statin plus ezetimibe. So we wanted to see what was the outcome of this. And remind you that those in dual therapy, simvastatin plus ezetimibe will improve it. Among all endpoints, ischemic stroke was the most reduced by 21%. So what about in TST trial? Those on dual therapy had a 41% relative risk reduction, and the risk reduction on statin monotherapy in those on the lower target group was not quite significant. So we were a bit surprised by this, particularly because both groups on dual and monotherapy had similar achieved LDL cholesterol, but look, they had different starting points, 10 milligram difference between those on dual therapy, 141, and 131 on monotherapy. So probably the magnitude of the reduction mattered. So we further wanted to see what was the outcome in the lower target group when once they had more than 50% reduction in LDL cholesterol from baseline. And here you see those with less than 50% reduction, more than 50% reduction, and you see that in this group there was 39% relative risk reduction, very significant. No significant reduction in the other group. So we know now that the guidelines have moved after the, as we will see, after the TST trial, the HA recommend that after a stroke and atherosclerotic disease, we should be less than 70 milligram per deciliter. But not only the target is important to consider for the clinician, but also the magnitude of the reduction, and we should make sure to have more than 50% reduction in LDL cholesterol. How about hemorrhagic stroke in TST? We had 31 hemorrhagic strokes. 16 had an LDL cholesterol just before the event above 100, and 15 below 100. So this was not a matter of LDL cholesterol, and we found no association. So some key subgroup, important key subgroup, particularly diabetes. As usual, diabetic patients did well in the lower target group with 43% relative risk reduction, very significant, and an NT of 17. So diabetic patients are really benefiting from once they have causal atherosclerotic stenosis, they benefit from a low target LDL less than 70 milligram per deciliter. We also did a small trial nested in the TST trial, the TST plaque ultrasound study, and we had exactly the 400 patients were included, exactly the same contrast, and you can see that the IMT as measured by carotid ultrasound was more reduced in the lower target group compared to the higher target group, very significant. Giving a mechanistic explanation of the benefit we observed in overall TST trial. So this is the recommendation I told you. That is 2021 guidelines of the HAAC, saying that in patients with stroke, non-cardioembolic stroke, based on Sparkle, they should be on atorvastatin 80 milligram daily. And based on TST, patients with atherosclerotic stenosis at the cause of their stroke should target an LDL less than 70 milligram. That means that for the other patients, we are not linked with this target. Patients with small vessel disease, for example, those with microvascular disease in the brain, can be at a target LDL cholesterol 100 milligram per deciliter. So it opened the door for giving a drug like SPARM alpha activator in this population of patients and in others like cryptogenic stroke, which is a large group. Altogether, it's 50% of the patients. It opens the door to do a therapeutic trial looking at both stroke events and vascular cognitive impairment, which is very important again for the future. So I think this is a very important point for the development of pemafibrate. Given the result of the prominent, these patients cannot be in this kind of trial since they have causal atherosclerotic disease. They need to be less than 70 milligram LDL cholesterol. So if we want to try pemafibrate in a group of patients with macrovascular disease at more than micro and microvascular disease with an achieved LDL cholesterol around 100 milligram per deciliter, giving pemafibrate on top versus placebo, we can look at recurrence and vascular cognitive impairment. I think that would be very important to perform. So this is a residual risk we have. This is a tiregistry.org that we published some years ago. It was an international cohort of less than 5,000 patients, or less than 4,000 patients for this part of the registry. And you see that at 5 years, the risk was 13%. And dividing these patients into those with causal atherosclerotic disease, 20%. So a room for a lot of clinical trials, not with pemafibrate. But the other patients with atherosclerotic disease not causal or with no atherosclerotic disease could be included in a clinical trial, as I said just before. So the residual risk in TST is 10% overall. In diabetic patients, it was 17%, even much higher. So how to address the residual risk? We can go further down, particularly in patients with atherosclerotic disease, causal atherosclerotic disease, as recommended by the ESC guidelines, 2019 ESC guidelines. We can possibly use anti-inflammatory drugs. We can use perhaps proglitazone, I will show one slide, and GLP-1 receptor agonist, as well as triglyceride-lowering therapy. So first, I said that the time in therapeutic range was, on average, in TST, 53%. And we looked at those who had a therapeutic range between 50 and 100%, and you see that they had a strong 36% relative risk reduction. But had we used more frequently dual therapy, more than 1/3, perhaps 100%, or had we used a drug with a better efficacy, like PCSK9 inhibitor, then we would probably have a better effect in TST trial. So this is why it's interesting to consider another trial. And you see Sparkle is up here. This is a meta-regression analysis we've done several years ago. And you see the big names of the trial clustered during this regression line, along this regression line. And the Sparkle trial is the outlier up here, but when we split Sparkle into Sparkle without atherosclerotic disease and those with atherosclerotic disease, you see that those with atherosclerotic disease clustered with other trial addressing ASCVD. TST is there. So really on the regression line. And if we consider that in Sparkle we had 40% LDL reduction coming from 133 to 73 milligram per deciliter, in the Sparkle atherosclerotic group we had a 31% relative risk reduction. In TST, we had this reduction. If we go down to 30 milligram, we may have an even better relative risk reduction. So this is a case for a new trial that is now considered for a grant in France, the TST40 trial, since we will target 40 milligram per deciliter in patients with atherosclerotic disease, and 2 events during the first 2 years, the last 2 years. Because you know that in Fourier, in patients randomized with a stroke, they had a similar achieved LDL cholesterol in the evolucumal group, and they had a significant reduction in the primary endpoint and in ischemic stroke. So this is but when we looked at ischemic stroke, this is ischemic stroke overall, but when we looked at patients randomized with an ischemic stroke, there was no significant reduction. So to convince vascular neurologic to prescribe PCSK9 inhibitor, we need a trial, and I think that the TST40 trial will be as effective as Sparkle or TST to prompt the prescription of this medication in our patients. So now the current trial we are doing is the RISK trial, as I said yesterday, which is called colchicine low dose versus the standard of care. It's an open trial, 2,800 patients with ipsilateral stenosis, causal atherosclerotic stenosis, and they are re-randomized in a factorial plan ticagrelor versus aspirin. So it's a long-term trial, and we have a lot of data to show that ticagrelor could be superior to aspirin without increasing bleeding in this group. We'll see. So how about pioglitazone? As Peter Libby mentioned this morning, there has been the IRIS trial funded by the NIH showing a significant effect on stroke or myocardial infarction, 24% relative risk reduction, not quite a significant reduction in stroke only. The uptake of this trial has been very weak among the stroke community because of the fear to have a complication with heart failure, probably. GLP-1 receptor agonists are really potentially very interesting for stroke patients. This is a meta-analysis published in Stroke recently showing a potential of a 17% relative risk reduction. So if we had to target the right population in stroke patients, that is stroke patient with atherosclerotic disease and diabetes, then we may expect a better relative risk reduction. So it's difficult, it's hard to convince. They have done a lot of trial, and during all these years, I tried to convince these companies to do a dedicated trial to stroke, but it was not possible. Again, I should say. So you will see that in the next talk. This is the REWIND trial, and this is an analysis of cognitive impairment. You see 10,000 patients, median follow-up of 5 years, and they had a 14% relative risk reduction in cognitive impairment. So you will see in details with the next talk, in the next talk, this result. And I think it's very important for us because we can have a dual endpoint, which is stroke and vascular cognitive impairment in a trial with a SPARM alpha activator. So atherogenic dyslipidemia. In TST, there was a strong trend, I should say, for a reduction, but of course we are not powered to find something in this subgroup. But there was a strong trend, and we had evidence from the PERFORM trial, 20,000 patients, and SPARKLE trial, 4,700 patients, in which we selected those who were on statin. Okay, and here in PERFORM, you see 10,000 patients, 3,000 patients in SPARKLE atorvastatin group. And you see, according to the definition of whether it was a light definition of atherogenic dyslipidemia, it was 10% of the sample, or a more stringent definition, it was 3% of the sample with atherogenic dyslipidemia. In TST, it was 10% of patients. It was only atherosclerotic disease, so we had 10% of the patients with atherogenic dyslipidemia. So in PERFORM, you see that those with atherogenic dyslipidemia explain part of the residual risk with an hazard ratio of 1.36, an adjusted hazard ratio of 1.23. So it's an interesting area that we should explore to reduce the residual risk in patients with stroke. So pemafibrate, you all know this slide from Jean-Charles, and another slide from Jean-Charles, but also you saw that with Régis Bordet, that SPARM alpha may inhibit amyloidogenic pathway, inhibit tau hyperphosphorylation, inhibit neuroinflammation, since the brain is full of inflammation after multiple small infarction in case of microvascular disease, elicit enzyme, antioxidant response to oxidative stress, ameliorate glucose and lipid dysmetabolism, stimulate autophagy, and reassess vascular dysfunction. So, stroke-cog collaboration, Regis Bordet told you about that. They showed that the risk of cognitive decline after a stroke is real. And we can say that at 3 years after a stroke, 30% of the patients had some form of cognitive decline. And this can be used as an endpoint. In conclusion, in the Sparkle trial, diabetic patients, atorvastatin 80 milligram reduced the risk of stroke at 5 years by 30% in a mixed population of stroke. In a TST trial in diabetic patients, there was a 43% relative risk reduction in the lower target group. In patients with atherogenic dyslipidemia, the point estimate was 36%. And dual therapy with statin and ezetimibe reduced the risk by 41%. The magnitude of LDL cholesterol reduction was as important to consider as a target to achieve, since patients in the lower target group who had a more than 50% LDL reduction from baseline at the 39% relative risk reduction, while those with less than 50% reduction had only 4% relative risk reduction. And residual risk in stroke patients is substantial, and brain health is a major public concern, with vascular cognitive impairment in 30% of patients at 3 years. New targets being tested are inflammatory vascular risk, new antiplatelet therapy, pioglitazone and GLP-1 receptor agonists should be considered, and reducing further down LDL cholesterol is really something to do in a trial. Atherogenic dyslipidemia in diabetic stroke patients explain part of the residual risk, and that should be addressed by a new trial. Given its properties, pemafibrate should be tested in patients with non-atherosclerotic, sorry, there is a mistake here, non-atherosclerotic stroke patient in prevention of vascular cognitive impairment and outcome stroke. Thank you for attention.